So we will now hear from Dr. Erinn Bailey-Sawatzky, who comes to us from Alberta, Canada, a recent PsyD from California Southern University. You received your degree just a year ago. And I am bringing Erinn to your attention because she conducted an extensive literature review on psychologists prescribing practices and efficacy for her doctoral project. Specifically, her literature review was analyzed to determine if prescribing psychologists are competent prescribers based on their education and training. And you looked at the comparative education of psychologist prescribers to other mental health prescribers. And then you looked at the utilization of prescribing psychologists in the United States. And what you found, to your great happiness and our joy, of course, is that prescribing psychologists are certainly competent, what we've always believed that we are, and you found that prescribing psychologists have a competence akin to the level of competence like psychiatrists, and you found that from feedback from other prescribers, from psychology students, from clinicians, and that you also, I believe, have been involved in lobbying for passage of RXP legislation in Ontario. Is that right? Have you been involved in
Yes,
lobbying
that's
as well? And so with this research, when I first talked to Erinn, I said, well, you have to apply for the Patrick de Leon Prize from Division 55. You did, and then you won it in 2025. So congratulations. And your former advisor is on Zoom with us as well, Dr. Carolyn Ortega. I think I see her. Hi. Thank you. And so
Hi,
you have,
everybody.
hello, welcome. So good to meet you both. And so Dr. Erinn Bailey-Sawatzky, you have a PowerPoint, and you're going to be able to do that from where you are sitting. Okay, thank you.
Okay, well, thank you very much for having us. Dr. Ortega and I have the pleasure of presenting this research recently at this Canadian Psychological Association conference this year, and now with all of you, and in October, Global Psychological Science Summit, so we're pretty excited. So thank you to Dr. Rumreimer for the opportunity to present this information to all of you today. So just quickly, it was a systematic literature review, 144 unique studies to use. I used a biopsychosocial framework and then an evidence-based framework as well. So I had followed RXP literature and advocacy efforts for many years, so I decided to design my research questions around the areas that seemed to be hotly debated between opponent and proponent arguments of RXPs. So the goal for me was to be able to show what the research says versus opinion, and to have a comprehensive resource available for psychologists in their advocacy and education efforts. So the 4 questions I had are, are RXPs competent and safe prescribers? How are they trained in comparison to their medical counterparts? How have patients and colleagues received RXPs? And then what was really important for us in Canada was a question around how are RXPs being utilized in the comparison. So just quickly, safety and competence. None of you in the room are really going to be surprised about this. RXPs are safe and competent. They have hybrid skill sets. They're safely treated medically complex, often referred by physicians. Physicians are relying upon RXPs as specialists in integrated care, seeking access for patients, and really was seen as a natural evolution for psychology. So I was able to assess RXP safety and competence through several vantage points in the research. So tested content knowledge based on their ability to treat really complex patients, based on low liability malpractice insurance premiums for RXP, based on how colleague prescribers would refer to them and rely on them, how they aren't abandoning their psychological roots for prescribing practices, and really we're seeing the research has been all quite consistent to, over 3 decades ago, the findings from the de-administration project. So these findings really help to debunk those opponent arguments that have surfaced over and over again over the years. The false claim that RXPs will harm patients due to their differences in training to prescribe, because they weren't taking a traditional MD or NP program. It shows the ability of RXPs to be trained outside of the DoD program 30 years later and maintain safety and competence. Really, there's an inability of opponents to prove that lack of safety data on RXPs to back up those types of claims. So it was quite interesting to see. Now, the second question was around education and training in comparison to other prescribers. And the themes were really that RXPs have appropriate levels of education, clinical experience. They have that national exam also to pass prior to prescribing. So really the key point here is RXP training is different, but it's not inferior to other mental health prescribers. So the psychological model of training RXPs is producing highly qualified prescribers. So, all of you following, RXP information, and those of you who are RXPs know that there's been a lot of debate in the literature around the differences in training and trying to conclude whether that would make RXP safe or not. No research on RXP practice or tested post-licensing competency, aside from speculations, could actually prove RXPs were unsafe due to their differences in trainings. RXPs have once again proven through research that they have expertise akin to psychiatrists. Some of the results had shown lower competency in psychotropic prescribing was really around, GPs and general nurse practitioners who are doing over 80% typically the psychotropic prescribing for patients. So there's no evidence-based reason not to consider RXPs and psychiatrists equal specialists in mental health care, as RXP differences in training to prescribe clearly trains them to a specialist level. So again, opponent arguments against RXPs are not supported. That idea that RXPs, we've seen this a lot in the literature, RXPs should be trained to be physicians or NPs if they want to prescribe competently, and that is actually shown to not necessarily be ideal. RXPs have an exceptional amount of education in comparison to other prescribing providers. Prescriptive authority training is not a backdoor to psychiatry, but a route specific to psychologists and not physicians. And many prescribing professionals with gained scope of practice to prescribe are also not trained in medical models as physicians. So RXP training, of course, is different, but not inferior. And the research shows that RXPs are working at specialist levels, not at the level of psychotropic prescribing that GPs and NPs can be found working at. So with evidence, one can assert that psychiatrists, prescribing psychologists, and even psychiatric nurse practitioners are of this, higher competency in regards to psychotropic prescribing, which signals the appropriateness of all three clinicians' training models. And again, clearly the recommended APA model for prescriptive authority is more than adequate in comparison to some other providers. So both, psychiatry, psychiatric nurse practitioners, and RXPs, the training program seem to be doing what it needs to do. Now, what's really concerning that comes up is that, when we look at RXPs have typically the most restrictions on their prescriptive practices, often more so than general physicians or general nurse practitioners, yet RXPs have an assessed competency at the level of psychiatrists and are referred patients in practice by GPs and NPs, similar to how a psychiatrist would be consulted. And then the third research question was around the experiences of patients, colleague prescribers, psychologists, and psychology students. And the themes of this was really RXPs have been evaluated positively by the medical colleagues who practice with them. Patients experience RXPs positively. And RXPs continue to have support from the psychological community, both clinicians and students, whether they intend to gain prescriptive authority for themselves or not. So not one study actually showed negative experiences in actual practice with RXPs. Physicians rely on RXPs for their expertise, similar to psychiatrists. They're sought out for consultation. They're having patients referred to them. RXPs are working from the biopsychosocial spiritual framework of care, resulting in positive patient and colleague reported experiences. They have that large base of support from practicing psychologists and students. Highest interest in prescriptive authority is really those early career psychologists, those with high debt loads already from school, and those coming out of or in PsyD programs. And really, without supportive legislation, psychologists will not likely waste their time and money. So we need that legislation piece in there. And in Canada, it's very similar. A majority of psychology clinicians and students surveyed, and most recently surveyed this year, continue to note interest in prescriptive authority. We just need one province to move it forward.
That's right.
So again, the findings do not support opponent arguments about RXPs. Those patient experiences of prescribers really are not well documented in the research for any other prescribing professional, but it was really important to be able to show this. Researchers noted that to show the patient experiences with RXPs, so that was really smart to be able to show how they could connect with patients and meet their needs in a way that consumers would be supportive of. And RXPs were found to be increasing medical providers' confidence with the mental health care of their patients. Physicians found that when they were embedded in their family medicine practice to be a really valuable asset, helpful to their patients, improving access. Colleague prescribers, interestingly, were more favorable of prescriptive authority for psychologists when they were educated first on RXP training prior to being surveyed. So there's still a need to debunk the myths around, it's a weekend training program to prescribe and then, we set them loose. Patients are extremely satisfied with their care and they like the shared decision-making models of RXPs. Patients also appreciate that hybrid skills at work as well as prescribing psychologists, empathetic skills. So one could also consider the lack of complaints from patients via malpractice or lawsuits as another indicator of positive patient experiences. And RXPs themselves in the research feel they are making a positive impact on patient care and access. So that's also important. And then the last question, before I hand it over to Dr. Ortega, this was a really important one, maybe not so much for you guys in Illinois, you're doing the work, but for Canadians to have an idea of how could we use RXPs. So I wanted to dig into that as well. So RXPs, this, they're extending services in primary care in hospital settings, they're taking on positions in educational institutions and federal health departments, all while reaching that population of patients without access to professionals well-versed in psychotherapy and psychotropics. So some of them you'll find participating on call schedules with psychiatrists, at times having full medical privileges like physician colleagues and seeing patients in clinic environments. They are contributing to increasing access to care wherever they are, with better mental health outcomes in states that have RXPs. They're reaching underserved and marginalized patients. They're receiving a high number of referrals. They automatically increase access. One of the things that came up often in the literature is the continued medical dominance found in regards to RXPs, a bit highly emotional and sometimes lacking research to support their claims of patient safety. And we know this is likely to be mirrored in Canada as we move some of this forward there too. So there's no evidence on RXP practice over the past 30 years that has found RXPs to be unsafe.
All right, thank you so much, Dr. Erinn. Yeah, I will try to be as quick as possible because I know for all of you there, not only are you exposed to some wonderful decorations, just looking at it looks like a treat, but just looking at the food on the table, I'm sure your dinner will be lovely. So just, a minute or two to go over some of the recommendations. We presented at the Canadian Psychological Association in June for the annual convention in Canada, and this year was in St. John's. So many of the things that really we covered there were about why this would work in Canada, especially based on the medical model, positive there, but really dovetailing into what the APA has already set up. So there's really no reason that Canada couldn't really carbon copy that really with its CPA to do that, because a lot of what CPA already borrows very heavily from APA as it is. So this is not really foreign to that. Another aspect is really thinking about the evidence-based practice, and looking at that. Very often, when some of these opinions are even discussed in the field, and this is even among psychologists, it's not really anchored into what the research has to say about what prescribing psychologists do. So really looking back at that and looking at what, we have a lot of studies published in the US already about that and really using that in Canada as well. In Canada also, as Dr. Erinn mentioned, recognizing the debt load, right? And so very similar to how in the US we have certain packages like at federally qualified centers to attract talent for psychologists. That could be something similar in Canada for recruiting folks that were qualified to do this if they went through the whole training program. Because again, this is not just a weekend deal, as many of you that already have accomplished becoming prescribing psychologists. It is a long road. So, having that support to support those individuals to serve back in those communities is needed. Really supporting the legislative changes in Canada, very similar to the US. It's a bit fractured. So, there is the federal, looking into Canada, but also looking at it at the province level. So all of this would happen at individual province levels, and each of the provinces also have very different regulations for psychologists. So acknowledging that and working at that ground level about how would that look like within the provinces, ensuring that prescribing psychologists also had full hospital privileges and such, and billing practices that would have to be on parity with other medical professionals. And again, that will vary by province. And then, really looking at also for the legislators, it's really important that, a lot of the legislators acknowledge and openly talk about the turf protection that really comes up with this. Sometimes the pushback comes from, other professions feeling like we're encroaching on their ability to do things. But really, medical providers, physicians have unlimited license to do anything. And so they can do assessment, they can do a lot of what we do already. And so this is not really truly encroaching since we have to do, above and beyond really to go on to do prescribing. So, really in Canada talking about that because there's some, misinformation sometimes when this has come up and I know we encounter that at CPA talking about that. It's just, well, how long is the training? And so, yeah, this is not a fly-by-night kind of operation. So I'll pass this back to you.
Thank you. Thank you so much, Dr. Ortega. So good to meet you. So good to hear from you. I'd love to stay in touch with you.
Thanks so much, Dr. Ortega. And Beth, I think that sums up kind of the key messages, that and information from the research that we wanted to share today. And certainly if anyone would like to get a full copy of the research, we'd be happy to send it to you.
We want to thank you very much for the research that you've done and the presentation that you gave to us. It was quite helpful for us and be helpful for those around the country and around the globe who are now just initiating prescriptive authority movements. Congratulations on the work that you've done. Appreciate everything that you're doing right now, and we certainly support your legislative movement in Canada.